Good morning. Thank you for having me at this beautiful place. Professor Bouzid and I had quite some overlaps and interactions in the past on rheumatic heart disease. My personal focus is on rheumatic heart disease, but as a department, we are really focusing on closing the gap between an infrastructure which is first world and a third world population. So of course we do the usual, we train surgeons from many African centers, but at the same time, one of our major tasks is to really find out what needs to be changed in the approach which we have at a first world infrastructure, which is on-site. And Professor Capondier knows that too well from Saigon. When you go from missions to an on-site institution, you have totally different opportunities. So this is the reality of an environment like that. It is shocking from the social standpoint, but it is actually rather reassuring that in an infrastructure which is non-existent, we have the infrastructure at least to treat, and we must just find ways to do it right. On the one hand, you see Barnard and Ross were the same class in Cape Town in 1946, and the theaters on the left are our new cardiac theaters on the pediatric side. So this infrastructure is here, and if you look at the performance, we have the same drop in typical pediatric surgical mortality as everywhere else in the world, and we have a relatively high volume of almost 300 pediatric cases a year for a public institution. But these are the challenges. So you see Table Mountain, you can see there is the proximity to a beautiful modern city, and next to it we have all the problems coming with shanty towns, that is access, that is realization of problems, and that is of course the economy. You can see 75% of those children which arrive at our institution are malnourished. A very good other example which I picked out here is AVSTs. So 75% are trisomy patients who would most likely be terminated in Europe and in America, but these children are born in poverty, and therefore we have this high percentage of AVSTs, which is certainly a deviation from what you have. So the next step is, of course, palliation. Our patients arrive with comorbidities, very often very sick and late. So is it inevitable to palliate either shunts with banding or cyanotic lesions with shunts? Or are we just continuing with a practice of previous eras which hasn't got justification anymore? So if you just look at them at the baseline, we looked just at 6 years of shunting, and more than a third, almost 40% of the patients come directly from the ICU because of all the comorbidities and were shunted. And you can see that 14% needed reinterventions. That was at a time before we changed the politics. But if you look at the outcome of the palliation of cyanotic lesions, we have practically 30% mortality before we get to the final repair, and the rest has a high percentage of patients which get lost. So in the end, 36% get to their final repair. The same applies to left to right shunt lesions where pulmonary banding was for a long time considered a very good bridging palliation in such environments. And again, we looked into it, and if you look at the outcome, you have practically, in all cases, a cumulative mortality of 30% and a very low percentage of corrections achieved. And that X-ray is actually an 18-year-old patient, which was just overlooked, and it never occurred to him to come back for treatment. So the lessons for us, once a program is established, is of course focus on complete repair whenever possible. And you can see we have really pulled that through as far as we could in the past few years. And you can also see that the mortality of 11% is still a third of the cumulative mortality of palliation. And one also needs to make choices in an environment like ours. And whatever those choices are, if you go for primary repair, you may have to accept an initially higher mortality, which is still below the 30% most likely. And you may also need to rule out marginal candidates. So last point, on the health political side of how to deal with this interface situation is, of course, access to cardiac surgery. We have in Africa two types of access to cardiac surgery. We have practically anything between you and us. We have 22 centers for 1.3 billion people in Africa. This is primarily for adult patients and needs to be addressed. And as I will briefly mention at the end, it will certainly not be addressed by the first world, which doesn't even know what our problems are. So South Africa has a population of 55 million. More than 5,000 cases would be required on the congenital side. 40% are in the state service of the patients which get treated, but this is 84% of the population. So nationally, in a situation where we should treat 5,000, we treat 620, and in our institution about 350 of those. That means 25%, and this is all congenitals, that doesn't even start talking about rheumatics, less than 25% actually have access. If one looks at our own data, you can see that there is a clear dip in the increase of cases in '94 when the politics changed to the better, democratically clearly, changed to the better by getting focus on primary health care. However, it was clearly overdone because you can't have primary health care by chopping off the tip of the pyramid. So tertiary institution must just not fall through the crack, and you can see that in our numbers. There is something else. This is the distance decay Aldo Castaneda normally mentions. You see this is the Western Cape, 50 million people. This is normalized, and only the two centers draw the patients, everything outside, and this needs to be mentioned. They have very good general surgical facilities, but no cardiac centers, and they never find their way through. This is just a comparison of cardiac surgeon of my original origins from Switzerland and Austria per million. You can see the private hospitals in blue. You can see in red what we are on the public side, and Africa as a whole doesn't even exist. So just two slides to give you also an idea where the advantages may lie of being at the interface of first and third world. We have a very strong program trying to address those issues which can be addressed, transcatheter with a transcatheter approach. For instance, on the mitral side, you can see, I think I was the last generation using the TAPS dilator. It was a fantastic life-saving exercise. General surgeons put something in through a purse string in the apex. The same can be done with a little bit more sophistication, and we have, for instance, developed a very simple pressure-based device to just clip the two in, for instance, acute rheumatic fever, where we can at least dramatically reduce the A2P2 distance as a life-saving exercise. And just sort of the last glance forward, again, the opportunities of being at the interface by looking at the right ventricular outflow tract conduits. So if we aim at one-stop operations, we either avoid right ventricular outflow tract conduits because one would need to come back, or we have simple means to address it. On the one hand, we developed a synthetic simple valve which doesn't need calcification. We went one step further with our colleagues in Zurich to make it tissue regenerating, exactly what the third world actually needs. And even if it comes to ballooning of old ones, you can, we developed a hollow balloon for the front line. So this is just to highlight what the interface of first and third world means. And one last reminder, we have on the 3rd of December this year, the 50th anniversary of the first heart transplant in Cape Town. You are all very cordially invited, but it also highlights this contrast between first and third, probably better than anything else. Thank you very much.